Welcome, and yesterday the first clinical trial on hydroxychloroquine that I'm aware of, the first proper randomized controlled clinical trial on hydroxychloroquine was published, and I'm going to report it to you. Now, I know these scientific papers aren't for everyone. I'm not going to go into a great deal of detail, but enough so you can see where these researchers are coming from. But if you don't want to watch the video, let's skip to the bottom line. The bottom line is that if people have been exposed to COVID-19 and they then start on hydroxychloroquine, the hydroxychloroquine is not protecting them against developing symptomatic COVID-19 disease. And that's the evidence for that is pretty good in this paper. And there's additional evidence in this paper that's not as of high quality as what I've just said, but is still there, that it doesn't make any difference whether you take zinc or whether you take vitamin C with the hydroxychloroquine in terms of preventing someone who's been exposed developing the disease. And you'll see I'm being fairly precise here. I'm only saying exactly what this paper says and nothing else. So that's the bottom line. It doesn't seem to work. Once someone's been exposed, it doesn't seem to stop people becoming symptomatic or going on to test positive for COVID-19. That's the bottom line of this paper. But as well as that, I want to talk about something more ethereal when I've done that, and that is related to the crisis of trust that we're having. So we'll look at serious concerns that have been cast over a previous paper on hydroxychloroquine, and just a problem of trust we've got really generally with people that we used to trust, like scientific advisors and the World Health Organization and reputable scientific journals. And I want to just kind of summarise where we're at with that issue, because this is a problem really that we haven't had to this magnitude before, and I think it's quite a significant issue. So that's all I wanted to say there. Let's cut to the chase now on this paper, and it is an interesting paper. It is a proper randomised double-blind controlled trial. This is the only way we can be certain that a drug works. We have to have this meticulous process. We have to give one group the drug, we have to not give the other group the drug, and we have to compare the results between the two to see if the drug is having an effect. That's the only way we can do it properly. And it needs to be randomised and it needs to be controlled with this control group that doesn't get the drug. Anyway, let's dive into some detail now. So this was published in New England Journal of Medicine. So normally I would say this is a very reputable medical journal, and of course this is a very reputable medical journal, albeit some problems they've had lately. But when you read this paper, it is a pretty convincing paper. A randomised trial of hydroxychloroquine as post-exposure prophylaxis. So after someone's been exposed to the virus, prophylaxis is preventative. Does it prevent people becoming symptomatic? Published on the 3rd of June. So the background: whether hydroxychloroquine can prevent systematic infection after SARS coronavirus 2 exposure. It's unknown. Does it have a prophylactic effect or not after someone's been exposed? Now, the method here was a randomised double-blind placebo-controlled trial, which of course is excellent. So that means we have a group of people here who get the drug, and we get a group of people here who get the placebo. They don't get the active drug. And we can compare the results between the two. That's the experimental group that gets the drug. That's the control group that doesn't get the drug. So it's a experimental controlled group. And it's randomised, meaning whether people go into that group or that group is based on random allocation. Because if I, as a human being, or anyone who's organising a trial, tries to allocate people into the two different groups, human subjectivity will come in and that will interfere with the results. So it needs to be randomised. The probability of randomised mathematics is used to assign people to groups. So it's a randomised double-blind. Double-blind, single-blind means the people taking the drug or the placebo don't know whether they're taking the drug or the placebo. And double-blind means that the doctors or the assessors or the nurses or the scientists, whoever it is, who are recording the results from these people don't know who is in what group. So So who the heck does know who's in what group? Well, the answer is it's all coded. And someone will have an envelope with all the codes in, and they'll only crack the code at the very end of the study when all the results have been assessed, to make sure the people assessing the results don't introduce their human subjectivity into the results. And that's where the second blindness comes in. They're as blind as the people getting the drug. It's a double-blind trial. Covered data taken from the United States and parts of Canada, testing hydroxychloroquine as a post-exposure prophylaxis. Now, what they did here, this is quite clever. They had two groups. They had high-risk groups, people who were exposed and had high risk of developing the infection. And they had moderate risk groups, people who were exposed but at slightly less chance of getting the infection. Now, the high-risk group was mostly healthcare professionals, carers, people in care facilities, and family members of people who had been confirmed and tested positive. So in other words, these high-risk people were in close contact with people that would have been shedding the virus. And high risk was defined as less than 6 feet, that's just under 2 meters. So less than 6 feet for more than 10 minutes while wearing neither a face mask nor an eye shield. So in other words, these people's eyes, nose and mouths were naked, for want of a better term, exposed to the viruses that someone was shedding within a 6-foot range for more than 10 minutes. They were considered high risk. Moderate risk was while wearing a face mask but no eye shield, so they were considered moderate risk. Now, what sort of numbers were recruited here? Well, what they did was they recruited a total of 821 people that were asymptomatic. They were without symptoms, but they'd been exposed. And 719 of the 821 were allocated to this high risk category. So they were high risk. Presumably the other 100 or so, 102 or 3 were moderate risk. So most of these people were at high risk. And they were randomly assigned into the placebo group or the drug group, in this case the hydroxychloroquine drug group. Randomly assigned placebo or hydroxychloroquine group within 4 days of exposure. So these people had just been exposed within 4 days. In other words, you would expect them to have been incubating the disease. And the primary outcome is, this is what the researchers are trying to find out. Does that alter the incidence of people becoming symptomatic? And because some people develop the infection and they are asymptomatic, does it reduce the incidence of a positive test? So that's what they were checking for. Does this intervention, does giving this drug mean that someone is more or less likely to develop symptomatic disease after exposure or test positive for COVID-19 after exposure? So fine, fair, good question. Right, cut straight to the results. What were the incidence of new illness? This is people becoming symptomatic or people testing positive. Right, the hydroxychloroquine group, 49. So from this 821, they were assigned to the two groups, right? So in the hydroxychloroquine group, there was 414 people in the hydroxychloroquine group getting. So this group here, the drug group, that had 414 people. 414, yeah, that's right, 414 people. So that's a good size. That's a good size group. You can get good stats from that. Now, the people in the hydroxychloroquine group, 49 of them developed symptomatic disease or tested positive. And as we say here, that's 11.8% of them went on to develop the disease. Now, in the placebo group, they ended up with 407 people, which is fine. And of course, the statistics account for these difference in numbers, of course. So they had a good sample size in both groups. That group got the placebo. In other words, they did not get the hydroxychloroquine. And 58 out of them, 58 of that 407 developed symptomatic disease or tested positive. So that's the difference. So what we see here is the hydroxychloroquine group, 11.8% went on to get disease. The placebo group that did not get the hydroxychloroquine, 14.3% went on to get the disease. So we see that the people in the placebo group got more disease than the people in the hydroxychloroquine group. So the people in the hydroxychloroquine group got less symptomatic disease after exposure than the people in the symptomatic group. Interesting. But the p-value, the difference between the two groups, was p equals 0.35. So what you do is you take the results from this group and the results from that group, and you do a statistical test that compares the magnitude of the differences, because differences between two groups could arise by chance. So what is the probability that this result arose by chance? And this is where this p-value comes in. Now, if you have if p equals 1, that means there's a 100% chance that that result arose by chance. If p equals 0.5, that means there's a 50% chance that that result arose by chance. If p equals 0.1, that means there's a 10% chance that this result arose by chance. It is not a genuine result. If p equals 0.05, that means there's a 5% chance that that result arose by chance. And if p equals 0.01, that means there's a 1% chance that that result arose by chance. And what we say in science as a convention is p equals 0.05 or less, you can claim the difference is significant. P equals 0.01 or less, we can say the result is highly significant. But the difference between the two groups here, between the hydroxychloroquine group and the placebo group, even although there was less people developing symptomatic disease in the hydroxychloroquine group, the actual difference between these two groups, between 11.8% and 14.3%, the actual difference is p equals 0.35. In other words, there's a 35% chance that that result arose by chance, that it's not a genuine result. So what we can say is the difference between these two groups was not significant. Statistically, that 11.8% is the same as that 14.3%. They are not different. It is in the probability of chance that those results occurred, because the p-value is 0.35. So there's a 35% probability that that result arose by chance, and that is not a good enough result to accept that as a genuine difference. Now, of course, you could say there's a 65% chance that result did not arise by chance. But to say, well, I'm going to give you a treatment here, and I tell you what, there's a 65% chance I think it's going to work, that's not good enough. Imagine you get on an aeroplane and the pilot says, welcome to your flight to wherever it is. There's a 65% chance we will arrive safely at our destination. Well, I'd be off that flight like a shot, quite honestly. The odds just aren't good enough. So by convention, we want a p equals 0.05 or less. Ideally, a p equals 0.01 or less. And of course, if p equals 0.001, that's only a 1 in 1,000 chance that that result arose by chance, which is getting better still. But this wasn't, that was 35%. So what we have to say for good scientific reporting is that there was no difference between the hydroxychloroquine group and the placebo group. There was simply no difference. It did not reach statistical significance. Now, if the trial had many thousands more people in, it might have reached statistical significance. But we don't know that. That's speculating. We've no idea. So this trial is saying there is no significant difference, and these numbers are good. This is a reasonable sized data set. Side effects in the hydroxychloroquine group were 40% of people got side effects. In the placebo group, only 17% got side effects. So you might say, well, if these people were given a placebo in the control group, in other words, they weren't giving any active ingredient at all, how come they had any side effects whatsoever? Because what people were getting here was a completely inert substance. But because they believed it may well be a drug, they got side effects. That's what we call the nocebo effect. And of course, this is the brilliant thing about having these blind groups. If this group knew they were getting the drug and this group knew they didn't, then this group would get a placebo effect, or indeed a nocebo effect, and this group presumably wouldn't, because they know they're getting nothing. That's the whole beauty of it. But interesting, it shows the power of the nocebo effect in that 16.8% still got side effects. Now, the side effects weren't serious as they were in a previous study that we talked about. And really, you could call these side effects routine, so nausea, upset stomach, dizziness, headache. We get these with drugs all the time, and they're nothing life-threatening. It's not like the ventricular arrhythmias that were identified in the other study, nothing like that. Because, of course, doctors know how to give hydroxychloroquine. Doctors have been giving this for years for malaria, for rheumatoid arthritis and other autoimmune diseases. So no serious adverse reactions were reported, so that's good. So there you go, that data showing it doesn't work. But of course, the theory is, isn't it? The theory is well known here, that this is the cell here, and the virus can get into the cell here to reproduce. And zinc inside the cell has antiviral properties. That is what is believed to be the case. And the idea is that the zinc has difficulty getting through the cell membrane normally, but the hydroxychloroquine forms a channel. It's called an ionophore. The zinc can get in through this channel like that. Ionophore, it's the same derivative as an amphoror that the Greeks used to carry olive oil, or may still do, I don't know, carrying olive oil and wine around the place. So that's kind of the rationale, that the hydroxychloroquine acts as this ionophore to get it through the membrane. So in theory, that sounds pretty convincing. Does it work in practice? Well, this is interesting. Now, I read all through this paper and I thought, that's interesting. It doesn't mention zinc. There's no mention of zinc throughout the paper. Therefore, it doesn't answer any fundamental questions. And it's a pity that zinc was not included in the official trial data. But it just so happened that about 20% of the people in the trial were taking a zinc supplement anyway. And the team were able to analyse that data. Now, of course, immediately you can see this is not blind. The people knew they were taking zinc, and those not taking zinc knew they weren't taking zinc. But nevertheless, even though it was a relatively small sample, about 20% of the whole number I think it was, people in the hydroxychloroquine group, in other words the ones that were taking hydroxychloroquine, 15% of those who were taking zinc developed new disease, and 10% not taking zinc developed new disease. So if people were taking hydroxychloroquine and zinc, taking zinc, then 15% of them got new disease. If they were taking hydroxychloroquine and zinc. If people were taking hydroxychloroquine without zinc, 10.8% of those got new disease. In other words, although it's not statistically significant, more people who were taking zinc got new disease. If people didn't take zinc, there was a slightly lower chance of them getting new disease in this hydroxychloroquine group. Not significant differences, but what it's saying is that there's not an obvious benefit from taking zinc with the hydroxychloroquine. Now, having said that, to be definitive about this, we would need a randomized double-blind clinical controlled trial with large numbers that addressed purely the difference between a group taking hydroxychloroquine alone and a group taking hydroxychloroquine with zinc. That would give us the definitive answer, but that trial does not exist as far as I know, certainly hasn't reported. So sort of straining a bit more data out of this trial, the intimation here is that taking hydroxychloroquine and zinc together is of no benefit. Now, the placebo group, who would take, some of those were taking zinc. Taking zinc, 15.4% developed new disease, and not taking zinc, 14% developed new disease. Now, you can see the difference between those numbers, of course, is not significant. But again, it does seem to be showing that zinc has not got an obvious protective effect if it's taken on its own without hydroxychloroquine. And this relative risk thing is interesting. So the relative risk with zinc users was 1.23. Now, the relative risk means that if the relative risk is 1, if RR equals 1, relative risk equals 1, then that means there's no protective effect from the drug and there's no damaging effect from the drug. But to get a protective effect from the drug, in this case the zinc, then the relative risk has to be less than 1. But the relative risk actually from this limited data turned out to be 1.23, indicating that the chances of getting new disease if you were taking zinc was increased by, I think that works out at 23%. What it means is if your chances of 1 and the ratio is to 1.23, then if you don't take the zinc, your chances of 1 of getting the new disease, and if you do take the zinc, your chances of 1.23. So there's an increased chance if you're taking zinc from this data. Now, the other one is hydroxychloroquine and vitamin C. And in the hydroxychloroquine group, if people were taking hydroxychloroquine and vitamin C, so hydroxychloroquine and vitamin C, then taking vitamin C with the hydroxychloroquine, 14.3% developed new disease, and not taking vitamin C, 10.3% developed new disease. Again, these numbers aren't significantly different, but again, it means that the people taking the vitamin C with their hydroxychloroquine had a slightly increased chance of getting new disease. That's what the results show. What about the placebo group? Well, the placebo group, who remember, weren't taking hydroxychloroquine, if they took vitamin C, 20% of those developed new disease, 20.8% developed new disease. Those not taking vitamin C, 11.2% developed new disease. In other words, from this limited data set, taking vitamin C increased the chances of getting new disease. 1.6 relative risk. 60% increase. So not taking vitamin C was a chance of 1 versus 1.6 rather people, the ratio of getting new disease if they were not taking vitamin C. So what do we conclude from this? Well, what we conclude from this is that this study is showing that if someone is exposed to the virus, then they take the hydroxychloroquine, that's not going to protect them from the disease, compared to a group that take a placebo. There's no difference between those two groups, statistically speaking, from this study. And while the quality of data is less, there's an intimation that taking zinc with your hydroxychloroquine doesn't help, and taking vitamin C with your hydroxychloroquine doesn't help either. In fact, there's a small intimation that taking zinc with your hydroxychloroquine would increase your risk of new disease, and taking vitamin C with your hydroxychloroquine would increase your risk of getting new disease. But that's not statistically demonstrated. So the first part about the hydroxychloroquine versus the placebo is statistically demonstrated. The part about taking zinc with the hydroxychloroquine is not statistically demonstrated. So to be sure about that, we would need a full double-blind randomized controlled trial where one group was taking hydroxychloroquine alone and another group was taking hydroxychloroquine with zinc, and then comparing those two groups. So in that study, the experimental group would be the hydroxychloroquine plus zinc, and the control group would be hydroxychloroquine alone. But there's kind of ethical difficulties there, because that study shows that the hydroxychloroquine is not working. So, but it could be done. It could be done, but it hasn't. So I don't know. So that's what we have to say about that. Now, I am going to talk about one other thing in this video. The Lancet and the New England Journal of Medicine, I think New England Journal of Medicine as well. So this study here was certainly in the Lancet. And we looked at this a few days ago. Hydroxychloroquine with or without a macrolide for treatment of COVID-19. Macrolide, remember, is that antibiotic. And we looked at this study, and again, it was showing that hydroxychloroquine wasn't effective. But the Lancet have recently issued a statement, and don't take my word for it, always go to the reference and read it. That's the full statement there. Same with the study I've just talked about. Don't take my word for it, go and look it up. Serious scientific questions about the validity of data, and the Lancet have issued an expression of concern. So far, they have not withdrawn the paper. So this paper is not withdrawn, but the Lancet have expressed concern over scientific questions about the validity of the data. Now, you'd have to do a full study on this to work it out, but it seems the data was taken from some firm that can't really fully demonstrate the provenance of that data. You might know more about that than me. I think life's too short to go into all that. Basically, we have to take the word of these scientific journals. So if the Lancet withdraws that paper, then that would be a bombshell, to be quite honest. And if it's wrong, they will do. So issued a correction regarding location of some patients. They do say so far the conclusion's not changed. But I do stress that that question mark I'm raising there has nothing to do with this paper that we've just reported on, which does appear to be a good quality randomised double-blind controlled trial. This is a separate thing. WHO anyways resumed its trials of hydroxychloroquine. There we go. Now, there is a bit of a crisis of trust at the moment. If these medical, we still do trust these medical journals, and they will correct themselves over time. I do believe that. That's what science does. Science is a self-correcting process. False data will not be allowed to stand. It will be corrected as a peer review and feedback from the scientific community filters through. Science is a self-correcting process. So even though it makes mistakes in the short term, they're normally corrected. But there's a crisis of trust with the World Health Organization. I think that's fair to say. Scientific and medical advisors, governments, and people are sort of struggling to know what to believe. So the answer is we have to believe the evidence.